Hello, I'm Daniel Griffin, and joining me today is
Sara Dong. Hi, everyone.
Welcome to another Puscast. References, as always, are available in our show notes at Microbe TV, the home of our multimedia empire.
I don't know if everyone has seen CID, OFID, and JID now have Twitter accounts that you can follow. It took a very long time, but it has finally happened.
I'm excited. I'm already following them, but it makes me think that this Puscast needs its own Twitter account.
Yeah, we'll have to work on that.
Okay, I know just the person. A review of the infectious disease literature for the last 2 weeks that we found interesting or entertaining. And now on to the literature, shall we? First article we have is going to be in the realm of viruses. But I alert everyone, we are going to try, at least for the moment, to be COVID-free. So if you want to hear about COVID, go to This Week in Virology, COVID clinical updates. But I think this is something that's gained a lot of attention. I'm hoping Sara has some thoughts on it as well. But the Mmwr early release, Acute Hepatitis and Adenovirus Infection Among Children, Alabama, October 2021 through February 2022. So in this release, they report on this new hepatitis mystery. During October through November of 2021, clinicians at a children's hospital in Alabama identified 5 pediatric patients with severe hepatitis and adenovirus viremia upon admission. An additional 4 children were identified for a total of 9 patients with hepatitis of unknown etiology and concomitant adenovirus infection during October 2021 through February 2022. These patients were from geographically distinct parts of the state. No epidemiological links among patients were identified. The median age of admission, 2 years, 11 months. So these are young kids. And 7 patients were females. All patients were immunocompetent with no clinically significant medical comorbidity. So basically, prior to this, to all appearances, healthy kids. All patients received negative test results for the common hepatitis viruses. So that's hepatitis virus A, hepatitis virus B, hepatitis virus C, and several other causes of pediatric hepatitis and infections were ruled out, including autoimmune hepatitis, Wilson's disease, bacteremia, urinary tract infections, and I will say acute SARS-CoV-2 infection. None of the children had documented history of previous SARS-CoV-2 infection. We may touch on that. Now, adenovirus was detected in whole blood specimens from all patients by real-time PCR testing. And the initial, they say viral load range, but we know that's sort of a genetic amplification, a DNA copy number of 991 through 70,680 copies per milliliter. Sequencing was performed on specimens from 5 patients, and adenovirus type 41 was detected in all those 5 specimens. Low DNA copy numbers precluded sequencing among 3 patients, and residual specimens were not available for sequencing from 1 patient. 7 patients were co-infected with other viral pathogens. Other detected viruses included enterovirus, rhinovirus, very similar sequence, so overlap when we report that, metapneumovirus, respiratory syncytial virus, and human coronavirus OC43. Liver biopsies from 6 patients demonstrated various degrees of hepatitis with no viral inclusions observed, no immunohistochemical evidence of adenovirus, no viral particles identified by electron microscopy. Now, I think this is sort of a smoking gun pushing people in a certain area, but I do want to encourage people to listen to TWIV, This Week in Virology, episode 894, for more background and a really deeper dive on this topic. But Sara, any thoughts?
Well, I was going to say, I think anyone who says that they know for sure what's going on probably doesn't quite yet. I think we really need more information, and we know adenovirus can be a tough bug, but I think what's probably most important from all these is a reminder for everyone to report cases if they think that it fits. And so the CDC is now asking for cases for patients who are under 10, who do have elevated AST, ALT over 500, and really just an unknown etiology for why they may have their liver dysfunction. And I think the other thing to try to keep in mind if you're worried about this type of case is seeing if you can save and hold samples from patients in the case that maybe we do get a better sense of what it is and hopefully could go back and do further testing. But yeah, I wish I had the answer, but trying to pay close attention to what new info comes out.
All right, fantastic. Sara.
Yeah. So this is a pediatric heavy papers that I selected. So chimeric antigen receptor T-cell therapy, so CAR T-cell therapy, targeting CD19 as a treatment option for children with B-cell ALL. And so I selected this paper to mention one useful fact, which is that the use of CD19-directed CAR T-cells has been associated with false positive HIV NAT testing, nucleic acid amplification tests. And so this article from Journal of Pediatric Infectious Diseases Societies, or JPIDS, from Drs. Alali and others, reported a case series of false positive HIV test results and gave a little bit of guidance on how to avoid this diagnostic dilemma. And so they had 3 cases at their children's hospital. And, I picked this because I think there are more and more centers that are starting to use CAR T-cell therapy. And even though it's not necessarily in our primary wheelhouse and ID, it's helpful to have a sense of what's going on. So lentiviruses are a subtype of retroviruses. And so once those genes are integrated into the cells, the NAT that's designed to detect specific HIV genetic sequences can be falsely positive. So what can we do? Well, the P24 antigen should not be part of lentiviral vectors and thus should not be present in someone who gets CAR T-cell therapy. So that's a more reliable test for HIV, which would be an immunoassay targeting P24. And so I know this fact has come up a couple times in immunocompromised host conferences I've been to, and I think is a really useful association to remember for both adult and pediatric colleagues.
All right, so the next article, immunological correlates of prevention of the onset of seasonal H3N2 influenza virus, published in the Journal of Infectious Diseases. Very creative study design, as they were trying to compare those that got infected with the flu and were asymptomatic. So we now talk about subclinical flu infections, still trying to discover what is an infection if you don't have symptoms, but somehow evidence that there was some viral exposure and some immune response versus those that were infected and got sick, right? That's what we normally think of as getting an infection. So the subclinical asymptomatic flu infections and the symptomatic got sick patients. So they reported that for antibody titers prior to the influenza virus exposure, the neutralizing titers and the ELISA titers against hemagglutinin, HA, and neuraminidase, NA proteins for the subclinical individuals were significantly higher than for the patients, whereas the neuraminidase inhibition titers and the antibody-dependent cellular cytotoxicity activities did not differ significantly between the subclinical and those patients that actually had symptoms and were, as we would think of, patients. So really interesting here, relevant as we talk more about what's the distinction between someone who gets exposed, who doesn't have any symptoms. We're starting to be jealous of those people. How did they have an asymptomatic COVID case and I'm here retching and in the hospital, versus those people that get infected and actually go on to have symptoms, maybe a horrible course. So. All right, the next one I want to hit on, again, use of a modified pre-exposure prophylaxis vaccination schedule to prevent human rabies, now that we've got these rabid anteaters running around. Recommendations of the Advisory Committee on Immunization Practices, United States 2022, came out also in the MMWR this month. Now, this is a big update. This is a change practice a little bit. Make sure you look up. Don't just keep doing what you've been doing for 30 years. During 2019 through 2021, the Advisory Committee on Immunization Practices made multiple updates to the rabies PrEP recommendation, including the following: a 2-dose, days 0 and 7, intramuscular rabies vaccination series, replacing the 3-dose schedule. A one-time titer or booster dose was advised for persons with risk for only recognized rabies exposure. Risk categories were redefined redefined, and the minimal acceptable rabies antibody titer was changed to 0.5 international units per ml. So we're thinking of our vets, our people with ongoing exposures. Why are they doing this? Well, they explained the 3-dose PrEP vaccination series is currently estimated at over $1,000, $1,100, and travel medicine providers have indicated that the largest target group is travelers to endemic rabies regions who might be otherwise unable to get those 3 doses in before they go off and travel, because at least 21 days are required to complete the series before initiation of travel. All right. I've got a few in a row, and then Sarah's going to jump in. But another article, be careful of those rabid anteaters out there. Long-term safety and immunogenicity of a tetravalent dengue vaccine candidate in children and adults. A randomized placebo-controlled phase 2 trial was published in the Journal of Infectious Diseases. This is actually a big topic throughout the world. Less so, but something that travelers think about. The tetravalent dengue vaccine candidate, TAK-003, is based on they say live. I'm going to keep replacing live with replication-competent attenuated dengue serotype 2 virus that provides a genetic backbone for all 4 vaccine viruses. The other 3 virus strains, TD1, 3 and 4 are chimeras, replaced by replacing the pseudomembrane and envelope genes with those from wild-type dengue 1, 3, and 4. Whenever people talk about live viruses, it reminds me of a scene in the Mel Brooks Young Frankenstein movie. I'm sure if that does that for everyone, or if I'm just dating myself. But this was a double-blind, randomized, placebo-controlled study conducted at 8 study sites in, they say, 4 countries. I didn't know Puerto Rico was its own country. Who's the president of Puerto Rico? I was just getting 3. I'm thinking that Puerto Rico, Puerto Rico, Colombia, Thailand, and Singapore. Who is the president of Puerto Rico? There were a total of 6 PCR-confirmed dengue infections. 4 participants in the TAK-003 group, 1.6%. 2 participants in the placebo group, 1.8%. 4 of these 6 dengue cases required hospitalization. They say 2 each, but getting kind of 2, 4, 6. Okay, I'm not getting everything to add up here. But they go on to say, and I think this is interesting, 3 years after the administration of the first 2 doses of TAK-003, persistence of antibody titers were demonstrated in 1.5 to 45-year-old participants in dengue endemic countries. The vaccine was well tolerated in this population, but I have to say, and I'm going to agree with the authors, the clinical relevance of antibody persistence needs to be assessed in ongoing efficacy trials. I was not as impressed with this article, but I thought it was important to share. For now, what do? We have DengueVax in the U.S., and in total, it's licensed in 20 countries. Now, what about DengueVax? DengueVax increased the risk of severe dengue in those who experience their first infection after vaccination. So to use this, we have to do serology testing first. We then have to make sure we only give it to people who have prior serology positive, because they might end up doing worse thanks to us giving them a vaccine if we're sort of priming them for that second antibody enhanced response. And also, there were excess hospitalizations for dengue among vaccine recipients aged 2 to 5. So still lots of work before I'm going to sign up to get myself that dengue vaccine.
Well, I'll jump us into bacteria. I have an article thinking about TB diagnosis in children, which if you think it's challenging in adults and children, it's even more so. And many ID docs would love to have additional tools available to help us with case detection, particularly those that would be easy to access and or point of care. And so in adults, CRP has been shown to correlate with TB diagnosis, especially if there is co-infection with HIV. And in fact, the WHO endorses CRP as a TB triage tool. So a paper was released in JPIDS, the role of CRP as a triage tool for pulmonary TB in children. And the authors, Jagannath and others, reviewed cases from about 300 symptomatic children under 15, so our cutoff for TB in children, in Uganda, and found that CRP levels were low in children with pulmonary TB. And in fact, the median was around 10 versus up to 80 milligrams per liter in adults that we sometimes see. So the performance of the CRP didn't seem to be as valuable in children as what we've seen in adults, and really unable to achieve accuracy targets as a triage test for TB, which certainly would have been a nice resource. It's interesting to think, it's not totally clear why this is the case, and maybe it has something to do with the fact that many younger children have primary TB disease rather than post-primary reactivation disease that we see in adults.
Okay. The U.S. FDA alert: factors potentially contributing to the contamination of packaged leafy greens implicated in the outbreak of a Salmonella typhimurium during the summer of 2021. I believe this was sent right to Dixon Despommier, the grandfather of vertical farming. This was a report of a multi-state outbreak of Salmonella typhimurium linked to packaged leafy greens produced at a controlled environmental agriculture indoor hydroponics operation. I'm not sure what else they were growing there. In total, 31 people got sick, 4 ended up in the hospital. According to the FDA, this highlights the dangers that can result from failing to ensure clean water is being used for that hydroponic farming. So if you're going to be growing anything in your hydroponic gardens, deep fry it first, please.
My next study is short course IV antibiotics for young infants with UTI from Lawrence et al. In Archives of Disease in Childhood. So UTI treatment in young infants is generally treated with initial IV antibiotics, which is really an international standard or guidelines, but it's variable, and there really isn't a lack of consensus on when is the right time to switch over to oral therapy. And so there's been data coming out supporting shorter IV courses in several of the larger pediatrics and hospital pediatrics journals in the past couple years. But this study demonstrated that treatment of non-bacteremic urinary tract infection in infants 90 days or less of age with less than 48 hours of IV antibiotics was not associated with severe complications, meaning bloodstream infection, meningitis, or death, or higher rates of UTI recurrence. And so they had about 60% of the 430 infants who were treated less than 48 hours. And the treatment failure, which is defined as a recurrent UTI, was only about 1%. So just a little more evidence to help us think about shorter IV courses in some of these young infants with UTI.
All right. This will be our deep dive, the real-world comparison of bezlotoxumab to standard of care therapy for prevention of recurrent C. diff, Clostridioides difficile infection, in patients at high risk for recurrence. I did not pick this just to demonstrate my ability to pronounce things that end with MABs, but this was published in Clinical Infectious Disease. And this was a study looking at the use of bezlotoxumab, Bex, we'll make it easy, a monoclonal antibody used to prevent recurrent C. diff diarrhea. Couple comments. This was not a prospective randomized control trial, but instead was a retrospective matched cohort study with the risk for confounders associated with such a design, right? So there are issues with looking at data this way. I want to put that caveat. Now, they reported that recurrent C. diff occurred in 11% of the patients treated with Bex compared to 43% in the standard of care cohort. What was standard of care? Mainly vancomycin, and most of those folks were getting an extended course. So I was thinking this was a good time to bring up another guideline that has come out while we're all focused on COVID, and this was Clinical Practice Guidelines by the Infectious Disease Society of America, IDSA, and Society for Healthcare Epidemiology of America. 2021 focused update guidelines on management of C. diff infections in adults. What were people thinking, putting guidelines out in 2021 during a pandemic? Who was reading these? Anyway, that was published in CID 6/14/2021. Maybe they thought it was the spring, cases were going down, maybe somebody would read something. Yeah, that's not what people are doing. Typically, I'm still seeing everyone treated for C. diff with oral vancomycin. Fortunately, most of us have moved past metronidazole or Flagyl, but let's go into this update. So what did they recommend? What are we supposed to be doing? One, for patients with an initial C. diff episode, suggest using fidaxomicin rather than a standard course of vancomycin. What? When did that change? Where was I? Where was everyone in my hospital? In patients with recurrent C. diff episodes, they suggest fidaxomicin rather than a standard course of vancomycin. For patients with multiple recurrences, vancomycin in a tempered and pulsed regimen, vancomycin followed by rifaximin and fecal microbiota transplantations are options in addition to fidaxomicin. And then number 3, for patients with a recurrent C. diff episode within the last 6 months, we suggest using bezlotoxumab as a co-intervention along with standard of care antibiotics rather than just standard of care antibiotics alone. Wow. Where have we been? So what are people actually doing? I have to be honest. A lot of people are just doing Vanco. And when the Vanco doesn't work, they do a little more Vanco. Are they saving money? Are they providing better care? Because that's what we like to do. Well, let's talk a little bit about that because we usually don't talk about, are we saving money? And we talked a little bit last time about vancomycin and said some negative things. So let's go with it. So vancomycin, let's say you write your script, 125 milligram capsules. I want you to take those 4 times a day for 10 days, $30 to $100 per capsule, somewhere between $1,000 and $4,000 for that treatment course. Some hospitals and compounding pharmacies are getting around this by basically giving people intravenous fluid vancomycin as a substitute. What about fidaxomicin? We're hearing here it's preferred, suggested as a better choice. 20 milligrams twice a day, 10 days, cost about $5,000. And bezlotoxumab, recommended dosing is about 10 milligrams per kilogram. So for a typical 80 kilogram patient, 800 milligrams as an ID infusion over 60 minutes, average wholesale price of about $4,000. And that's a co-intervention. That's $4,000 on top of everything else. Sara, what's going on?
Yeah, I feel like it's still a lot of vancomycin use out there. I mean, I feel like we try to give Bezlo when we can, but I agree. I feel like it's still, we're kind of in vancomycin mode still. I was going to mention there was a correspondence in CID from Madeline King, who's the first author, a review of ID guidelines, incorporation of economic evidence. And they actually took a look at the IDSA guidelines and if they incorporated things related to cost or price or insurance. And all of the guidelines mentioned something, but really how it was incorporated was at a much lower rate. And so they kind of just talk a little bit about how ID guidelines don't really consider costs in their recommendations. And I think some people would say maybe we should just make the recommendations we think are best. But while that shouldn't be the driving factor for decision making, I think it's hard to ignore the fact that costs affect patient care and they affect what they get. So I guess the question is, if we are going to bring in that economic piece and the cost, how do we do it in a consistent and sort of systemic way?
Yeah, I'm thinking ID docs who go to extra years of training to reduce their average annual salary, maybe not the right people to talk to about making good financial decisions for themselves or their patients.
Yeah. Well, I will move us forward before we spiral. My next paper is from Injecca and others in the Lancet ID, treatment outcomes 24 months after initiating short, all-oral bedaquiline-containing or an injectable-containing rifampin-resistant TB treatment regimens in South Africa, a retrospective cohort study. So they looked at outcomes at 24 months in adult patients in South Africa who either received a short, all-oral bedaquiline-containing regimen versus the injectable regimens, which include things like kanamycin or amikacin. And they matched patients based on HIV status, previous TB treatment, and baseline AFB smear and culture results. Of the about 10,000 patients, 14% had resistant TB, with about a little under 700 patients in both the bedaquiline and injectable group arms. And they found that patients in the bedaquiline group had significantly higher rates of treatment success at 24 months, so about 70% versus 57%. They had lower risk of loss to follow-up and a lower mortality risk of about 17 versus 22%. There wasn't really a safety comparison directly in the paper between the two options, but I think we all are aware of the toxicity risk that comes with injectable regimens. So I think a little of a push towards the oral regimen, but we still have a lot of work to do because if you look at that regimen, it is a ton of pills and a huge daily pill burden. So I'll move us to our next one. The ID Wiki guidelines are here. I had seen this pop up on Twitter, and now we have our official first consensus consensus statement in JAMA Network Open, use of novel strategies to develop guidelines for management of pyogenic osteomyelitis in adults. So this was led by Brad Spellberg and others. And the Wiki Guidelines group is an open access research project that was recruited from social media. And I actually wanted to read this directly. The Wiki Guidelines group formed on Twitter by participants who were dissatisfied with traditional guideline methodologies. So they tackled pyogenic osteo as their first topic. The other thing I enjoyed taking a mini break to learn about is I Googled the dinosaur that they mentioned in their opening statement. Osteomyelitis is an ancient disease with the earliest documented case in an unfortunate 250 million year old Dimetrodon with fractured spinal shaft. So if you look it up, you'll recognize it from Jurassic Park. But anyways, they addressed 7 questions. They made 2 what they called clear recommendations. The first being the recommendation for oral therapy as a reasonable option for any osteomyelitis, assuming that the patient is stable, there's source control, that they can absorb the medication in their gut, and that you have an available oral regimen. And so this is something we're working towards in internal medicine. Certainly on the pediatric side, the recommendations for osteo already line up with this, and we use PO as part of our normal care. And actually, speaking of guidelines published during the pandemic, there was a PIDS IDSA guidelines for acute hematogenous osteomyelitis in children's guideline release last year. And then their other second recommendation was a maximum of 6 weeks of therapy, and they actually created a chart of oral antibiotic doses. So I think the authors are hopeful that this is the future of guidelines, and I do have to acknowledge the speed at which this was released. What do you think, Daniel?
Yeah, I'm trying to figure out if Elon Musk gets authorship on these, but will now be. But on Twitter, it says, I think one of the big problems, and we've talked about this when we talked about the vancomycin, guidance, the vanco dosing, the vanco management, people are using guidelines from 2009, from 13 years ago. Things change pretty quickly. So I do think we need a quicker way of updating the guidelines. I'm not sure Wiki is the way to go. We'll have to see. But yeah, I'm not sure that the current way we do it is working. So I do think it's time for a new approach.
Yeah. So my next one is about Staph aureus, ID public enemy number 1. This is the feature of an opinion paper in CID from Drs. Holland, Bayer, and Fowler entitled Persistent MRSA Bacteremia, Resetting the Clock for Optimal Management. So we all know the definition for what is, quote, persistent MRSA bacteremia is not at all standardized. And I think there's a mandatory talk at every ID week talking about this. But the authors commented and they explained sort of presence of bacteremia over one day being your initial, what they called worry point. And then they provided this pathway that tried to note antibiotic failure and sort of that point when you need to change therapy at 3 to 5 days, assuming that you're on appropriate therapy and you have source control. I suspect that many ID clinicians have continued to hold strong opinions on what is their personal trigger point for persistent MRSA bacteremia and changing therapy. But this gives you some insight into some expert opinions. So
yeah, I will. So I don't know if you've ever met Vance Fowler, but what he likes to do is he likes to time it so he changes them from vancomycin to Dapto right before the blood cultures clear. So everyone thinks he's magical and calls him back for another consult. But
I see.
so I encourage that. I know ID docs don't care about money, but it's nice to get those consults coming in. And if you change that vancomycin to Dapto, you probably should just change it right up front. But anyway.
And I will mention I have one fungal paper for today. And it starts with the question, how often do we miss the diagnosis of histoplasmosis? So this paper from Mmwr and others in the Journal of Fungi entitled Frequency and Duration of and Risk Factors for Diagnostic Delays Associated with Histoplasmosis. So they used insurance claims and diagnosis codes, defined cases of histoplasma, and then identified what they called symptomatically similar diagnoses. So looking at those prior to the index histo diagnosis. And they estimated that 83% of patients with histoplasmosis had at least one missed diagnostic opportunity and an average delay of about 40 days. And they estimated an average of 4 missed opportunities as far as sort of contact to healthcare. And so they tried to pull out some potential risk factors for these episodes. And among a few items, missed opportunities were not surprisingly associated with visits on the weekend. So if only healthcare didn't stop on the weekend.
Okay, don't get sick on the weekend.
Yeah.
All right, we are moving to parasites, and be sure to listen to This Week in Parasitism, but we have some articles. Intestinal parasitic infections and associated factors among people living with HIV, attending Desi Referral Hospital, Desi Town, Northeast Ethiopia, a cross-sectional study published in AIDS Research and Therapy. These are the results of a cross-sectional study that was conducted from March to May 2019. The overall prevalence of intestinal parasites was 21%. These are the places I love to be. 11 different intestinal parasite species were detected. 11! Oh my gosh. What would Occam have to say? The dominant intestinal parasite species was Entamoeba histolytica, followed by Enterobius ramicularis, that's pinworm, by the way. Individuals who had a habit of hand washing after latrines were less likely to be infected. Oh my gosh, who saw that coming? About an 85% reduction. On the other hand, individuals who had CD4 counts of less than 200 were 45 times more likely to get infected with intestinal parasites. Bad news, the prevalence of intestinal parasites was higher than previously reported from the same study area almost a decade ago. Maybe the other bit of bad news, those of you who wanted to stop, keep washing your hands. All right, next article. Association of zoonotic protozoan parasites with microplastics in seawater and implications for human and wildlife health was published in Nature Scientific Reports. So this study addresses what the authors tell us about an unexplored area of research targeting the interaction between plastics and pathogen pollution of coastal waters. They investigated the association of zoonotic protozoan parasites, Toxoplasma gondii, Cryptosporidium parvum, and Giardia enteritica with polyethylene microbeads and polyester microfibers. Now, these pathogens were chosen because they have been recognized by the WHO as underestimated causes of illness from shellfish consumption and due to their persistence in the marine environment. They may have also realized that I particularly like these organisms. They reported that these pathogens are capable of associating with microplastics in contaminated seawater with more parasites adhering to microfiber surfaces as compared with microbeads. Given the global presence of microplastics in fish and shellfish, this study suggested a novel pathway by which anthropogenic pollutants may be mediating pathogen transmission in the marine environment with important ramifications for wildlife and human health. So stop throwing plastics in the ocean. Keep washing your hands. What are we doing? What a messy. All right. So I have miscellaneous because we are destroying our planet, and I want to make sure I mention that periodically. Maybe someone will notice. Starting to believe this global climate chaos, it may be real. I know that one scientist is not convinced. The paper, Climate Change Increases Cross-Species Viral Transmission Risk, was published in Nature. Now, the authors start by saying that at least 10,000 virus species have the capacity to infect humans. Way underestimate, by the way, folks there. But at present, the vast majority are circulating silently in wild mammals. The authors used a model of the mammal virus network and projections of geographic range shifts for 3,139 mammal species. We're just looking at mammals under climate change and land use scenarios for the year 2070. This model predicted that species will aggregate in new combinations at high elevations, in biodiversity hotspots, and in areas of high human population density in Asia and Africa, driving the novel cross-species transmission of their viruses an estimated 4,000 times. Because of the unique diversical capacity, bats account for the majority of novel viral sharing and are likely to share viruses among evolutionary pathways that will facilitate future emergence in humans. Who would have thought that viruses could come from bats? They suggest that these findings highlight an urgent need to pair viral surveillance and discovery efforts with biodiversity surveys, tracking species range shifts, especially in tropical regions that harbor the most zoonoses and are experiencing rapid warming. This is a very complicated paper. So I went looking for the pictures. There's pictures. It's okay. They have these wonderful figures with pictures showing potential opportunities for viral sharing and population density. For a deeper dive, listen to TWIV 896. And in the meantime, I will be moving to Greenland.
And that brings us to the end of this podcast. As always, the references for the show are available on microbe.tv, the home of the Microbe TV multimedia empire.
You can also find the Infectious Disease Puscast at Apple Podcasts, microbe.tv/Puscast. We love to get your questions, comments, and paper suggestions. So send them to puscast@microbe.tv and consider supporting the science shows of Microbe TV at microbe.tv/contribute.
I'm Sara Dong. You can find me on Twitter at swindong and Febrile Podcast or at febrilepodcast.com.
I'm Daniel Griffin, and you can find me at parasiteswithoutborders.com, on Twitter at Daniel Griffin MD, as well as on the other podcasts, This Week in Parasitism, This Week in Virology COVID Clinical Updates.
Thank you for this interesting consultation and allowing us to participate in this challenging case. We shall continue to follow along with you. End of dictation.
Thanks for listening. We'll be back in 2 weeks.
Another Puscast
is infectious.